welcome to another fabulous cafe site evening. For those of you who don't know what the format is, our speaker is going to give a chat for 30-40 minutes-ish, and then we'll have a break. 35. And then we'll have a break where you can have a chat, get another drink, whatever. And then we'll come back and we'll have an open discussion. Any questions Mr. Wujie is happy to answer, and just have a bit of a chat about what we've all learnt. So keep an eye on Facebook and Twitter. Our handles were up earlier. So with no further ado, I'd like to introduce Mr. Wujie, who's our guest speaker. He's a vascular surgeon from the Royal Bournemouth and Christchurch Hospital. Tonight he's going to give us a talk into repairs of our plumbing, the vascular orientation. I'd also like to welcome Mr. Simmons and Mr. Holford, who are two patients that Mr. Wujie's brought with him.
Well, they brought themselves.
Well, they brought themselves.
We found our way.
And thank you very much for doing so. Over to you, Mr. Wujie.
Thank you, Emily. It's very kind of you. Can I stand over there so I'm
Yeah,
out of the way of that? It's all right. Very kind of you to invite me tonight, and there's no formality here, so please feel free to ask questions as I go if you think I haven't been clear enough. But there will be time afterwards, as I said. So I cheated a little bit because I think I blew it up in the leaflet as being how to save your circulation in 2 easy steps or something like that. But I hope you'll forgive me with that license. So without further ado, now atherosclerosis is this generalised process whereby a normal artery, here's the cross section in an artery, and here it is end on, becomes more and more progressively diseased by the accumulation of what we call atheroma. It's a kind of, the Greek word atheroma is means gruel, porridgey stuff, and it does look a bit like porridgey stuff sometimes. And as it progresses, it narrows the diameter of the artery, the lumen as we call it, and that can lead to thrombosis or a clot forming, and that can cause anything depending on whereabout in the circulation it happens, from a heart attack to a stroke to gangrene or death. Now, if you asked anyone in Boscombe what they thought was the leading cause of death in the world, you're probably not going to hear the word atherosclerosis, but actually it is. In the world, people might think, oh, malaria or other infectious disease. Yes, certainly, 17.8% of deaths are caused by infectious disease, but nearly a third by atherosclerosis. When I asked my son, he said AIDS, and that's only 5.1%. And this is from the World Health Organization. Now, first of all, I'm going to talk about a kind of atherosclerosis which is associated with the process whereby arteries start to bulge, and in medical jargon that's called aneurysms. So these are bulges in arteries from the Greek and Sanskrit word for a dilatation. And the commonest things associated with atherosclerosis are smoking, high blood pressure, hypertension in medical jargon, family history, and high cholesterol. There are other causes such as trauma, infection, and connective tissue diseases, but we won't dwell on that. Here are a couple of aneurysms. Here are the knee joints, and here are the aneurysms in the superficial femoral arteries. Where can they occur anywhere. You've seen them in the superficial femoral arteries. This is in the abdomen, kidneys either side. This is called the aorta, this artery. The aorta in the chest can also be affected, and here in the femoral artery, just in front of the hip joint. Who gets aneurysms? Well, typically men like these, men over the age of 60 who are ex or present smokers, or who've had high blood pressure, or a family history, or just out of the blue for no particular reason. Who got aneurysms? Famous people who did. Well, actually Betty Garrett's not that famous, but she was in Laverne and Shirley, that American sitcom, as well as some films. This famous chap, Einstein, anyone know who he is or was? George C. Scott, American actor. And this guy, I had to put his name down because I wouldn't have remembered it, Vladek Sheybal, who was in From Russia with Love. That's one of the baddies. So just to remind you where an abdominal aortic aneurysm will be found, that's a picture of it, and that is a CT scan, computed tomography scan. How do you know if you've got an aneurysm? Well, you might have a high suspicion if a first-degree relative had one. You might find one by chance on a scan or examination. You might find out, totally out of the blue, by pain in your tummy or back, sudden collapse, and unfortunately some are found at post-mortem. So they account for 2% of all deaths in men over 65. 4% of men in this age group have an aneurysm, and accounts for about, in England and Wales, 6,000 deaths a year if an aneurysm were to rupture. And here's a chap who seems surprisingly happy after being told he's got this life-threatening condition, but found on ultrasound scan. So here are some scans. This is an ultrasound scan, and this measures at 7.5 centimetres. Here are 2 CT scans just to show a normal aorta, which is this little thing, the diameter there. There's the vertebral column, one of the vertebral bones, kidney on either side. And here's an aneurysm, just to show you how different it is from a real normal artery. What do you do if you have one? Well, you could watch it till it's big enough to need a repair. You could repair if it's big enough, or you could leave it alone because it's too risky to repair. In other words, the repair is more dangerous to your life than actually leaving it alone. Now, why repair it? Because as they get bigger, and here's the size of aneurysm in centimetres, and here's the chance of it rupturing. So as we get to 4, 5, 5.5, and then just after that, it starts to increase, the chance of it rupturing starts to increase quite dramatically with a small change in size. So if you imagine that the chance of you dying from an operation on this is about this % here, therefore it makes sense to wait till the aneurysm gets that big to operate on it, because the operation is then less risky than the size of it bursting. Does that make sense? Yeah.
Why does the chance of death go down?
Sorry, what are you looking at? This is the chance of it rupturing going
the
up.
chance of rupturing, but why does it go down?
This little bit here? Don't know. Statistics, probably. Now there's this thing, this is café scientifique, so I thought I'd make it a bit café and a bit scientific, if that's all right. So here's a bit of science. There's this thing, the Law of Laplace, which is to do with pressure and tension in the wall. Now, if you imagine this is a tube, the tension in the wall is equal to the pressure times the radius. When the tube becomes a bulge, like this, it's more like a sphere. And then the tension is the pressure times the radius divided by 2. So what this means is that as there's continued expansion, it produces a wall tension that becomes greater than that of the original cylinder. In other words, it's more likely to rupture, to cut a long story short. And here are some computerized images of measurements of the forces of tension in the wall of the aneurysm. And blue is the lowest tension and red is the highest. So you can see that there are points here where you get quite high tension. And funnily enough, when the aneurysm ruptures, it tends to rupture at that sort of point. How to repair it? Well, I don't know if you can... This is a chap called Arthur Voorhees, who was a Dutchman who emigrated to the US. And this is parachute, and this is a ruptured aneurysm. And the link is that Arthur Voorhees was doing some experiments with parachute silk. And he was sewing tubes of parachute silk to do experiments on repairing arteries in animals. And it so happened that a chap came to him who had a ruptured aneurysm, and he thought, well, let's give him a chance and repair his aneurysm with one of these, and a suture, and he did, and the patient survived. And that was the very first repair of an aneurysm, 1952. Here is one from 2014, from last week, in fact. The patient's feet are down here, and the head's up there, and that's the aneurysm inside the belly. If you open the aneurysm, make a slit in it, that's the inside of it, and you can't see very well, but this is a big metal clamp clamping the artery, the aorta, to stop the blood squirting out of here. And there's the hole of the normal artery, and we would sew in a piece of man-made tube into that hole there, and that's it at the end.
Excuse me, is the aorta the blood coming from the heart or back to the
Yes,
heart?
from the heart. So it becoming, there's the head end this way, so it's coming down there towards the feet. And that's what the patient's belly would look like afterwards. That is not the patient, but that is just to remind me that patients would go to intensive care afterwards. The recovery in intensive care about 48 hours, then on the ward another 5 days or so. Mortality. The chance of your dying from this operation in the UK at the moment is about 2.5%. Long-term prospects, once you're home, then you get back to the age and fitness of, the fitness of a person whose age matched with you. How else to repair an aneurysm? Well, this is a thing called a stent, which is a metal cylindrical splint, if you like, and this cutaway diagram of an artery. And you can cover a splint with cloth, and that's what this is. It starts off being a collapsed tube, and as you release the mechanism that holds it in place, it expands to become a fully covered stent, which you can imagine can sit inside the aorta and stop the blood from going out into the bulge. And we'll show some pictures of that in a minute. If you wondered where the word stent comes from, the generally accepted theory answer to that is that it comes from this name, Charles Stent, who was an English dentist. And you may have, if you've been to a dentist, had an impression taken of your teeth with a gadget of this sort of shape, which goes into your mouth and you bite on it. And in the 1800s, early 1800s, what they had was a very soft kind of gum, which didn't hold the shape very well. So Charles Stent invented a better version, which did hold this shape very well. And then in the First World War, surgeons used some sterilised Stent's compound to stabilise skin grafts and skin flaps for patients who had plastic surgery on large injuries to their face and head and neck. And then in 1954, a polyethylene tube was used to keep open a bile duct. The bile duct carries bile from your gallbladder into your bowel and helps digest fats. And the person who used that, the surgeon used it, called it a stent. And this is the only example of someone's name being used as a noun and a verb. So you can use it as a stent and to stent something. Now, what are stents made of? They can be made of most things, but the ones that we're going to talk about today are made of either nitinol or stainless steel. Nitinol costs quite a bit, and it's an alloy of nickel and titanium. And the name comes from the fact that it was made by the Naval Ordnance Laboratory in the US. It has this quality of being a memory metal. So you can have the memory in it, you can change the shape of it, and then you put it into water at about 30 degrees C, and it goes back to its normal shape, and it keeps that shape until you deform it again. It's highly biocompatible, so it's excellent to go in the body, and it has a surface oxide which stops it corroding, because you don't want any corrosive element in the body. And it has this super elastic quality, which is a little bit of science here, I'm sorry. So imagine this is the increasing diameter of the stent. Here it is in a circular cross section. And here it is as you compress it. This is the force which it exerts. So as you compress it, it exerts this outward force. And when it gets to a certain diameter, you can compress it some more, and it doesn't increase in force. And then when you release it again, when it starts to expand, it goes back to its original size, but at a lower resistive force. That's this super elastic quality. Stainless steel, on the other hand, is much cheaper, only £4 per kilogram as opposed to over 100. It's got 10% chromium and a bit of nickel in it. It too is biocompatible, and it too is resistant to corrosion. Current stent graft designs, there are 4 or 5 on the market, and these have to be covered to stop the blood leaking out, obviously, and they're covered in either polyethylene or polytetrafluoroethylene. And I hope if we've got time I'll show you a stent in real life. The fabric can either be woven or knitted. If it's woven, it can be either plainly woven in this fashion, or twill, where now is it the warp or the weft that goes up or down? I can't remember. But whichever, let's call it the warp. It goes over 2 of the weft rather than under and over like that, and it's a bit more flexible. Knitted fabric can be either knitted in this warp fashion or weft. But rather like a jumper, which is knitted, it'll have bigger holes in it than a woven one. And to stop the blood leaking out, they're usually coated with gelatin or some other substance. PTFE, polytetrafluoroethylene, was invented in 1937 by the American company DuPont. It's much lower friction than Dacron polyethylene. but it is also biocompatible, and that's what it looks like under an electron microscope. So the stent is large enough to fit in the artery, but that would make it too large to put inside the smaller artery, which it goes up in the groin. So it's compressed into a delivery system, which is then threaded up the artery from the groin to sit at the right point in the vessel, and we know it's in the right point by using X-rays to confirm that. And then, as the outer sheath is withdrawn, it releases the stent, which is rather like a pair of trousers with one long leg that goes into this iliac artery and one short leg. And then you have to extend this leg by putting a new extra stent in from the other side. So it all looks like that at the end. Okay? And that's what John Holsford has inside him. Some more views of the stent, and this is what it will look like sitting inside the aneurysm. So the blood will then come down from the heart onto each kidney and then straight down inside the stent graft to each leg, but not going into the aneurysm. So the aneurysm can no longer expand under the pressure of the blood. There are some special circumstances when it can, but I won't bore you with that. The first aortic stent graft was done in 1919. If you remember, the first aortic repair in the open operation was 1952. So a fair gap between the two techniques starting. And it was Juan Perodia, Argentinian, who did the first repair in 1990. And the second one was done a couple of years after in the US. So I was going to stop there and do the stent demonstration, but it might be more appropriate to go on and do that afterwards. And we'll talk about varicose veins. Is that all right?
Yeah.
Okay. Anyone bored yet? Okay. All right. Next. So varicose veins, a completely different part of the circulation. We were talking about the arteries, which carry blood away from the heart and supply your organs with oxygenated blood. The veins carry the toxins and the deoxygenated blood back to your heart for recirculation. So if you imagine, this is a diagram here of the venous system in the leg. This is the deep vein here, and this is called a superficial vein. So in every part of your body you've got deep veins and superficial veins, and the superficial ones will drain blood from the skin and the superficial tissues into the deep veins and back to your heart. Now, veins have valves in them which will allow blood to flow up in that direction, but if the blood wanted to flow down, which it will do when you stand up with gravity, those valves are specially constructed so they'll shut and the blood cannot flow down. If the valves are damaged or malfunctioning in some other way, the blood will then leak back down. And you can imagine that blood will then, because it leaks down, it'll just collect and distend the veins, bloat them even more, and you might imagine bulges in the veins appearing like that. And those are varicose veins. If you go down to Boscombe Beach, you'll probably see a few of those, or worse, I don't know. And also note how the skin here has got darker, and that's as a result of skin damage caused by the high blood pressure in the veins. And how high is the blood pressure? Well, if you imagine a column of blood that tall back to your left atrium, which is the part of the heart from which that comes, that's over a metre in most people, and that's a metre column of blood exerting pressure down here. If the valves were working, it wouldn't exert that pressure because the valves would stop at various points the blood flow. Complications that you might find with varicose veins: bleeding, of course, if you were to cut the skin or knock your leg on something sharp. Phlebitis, which is an inflammation of the veins here, quite painful, red, tender. Skin changes, which you saw on the previous picture, this darkening of the skin here. If you're really unlucky, you could get ulcers, deep vein thrombosis, and these symptoms, which are nuisance symptoms, pain, ache, itching, heaviness, and of course some people don't like the look of them. How is the skin damaged? Well, because of this high blood pressure, this is a picture of the inside of a blood vessel. These are red blood cells, these flattened disc-shaped ones, and these are white blood cells. They're not normally coloured white, they're just coloured white in this picture to make it look. Anyway, they're called white blood cells, and they're trapped by the high blood pressure against the wall of the vessel, which is called the endothelium. They then release their components, which are quite damaging to the endothelium. That causes inflammation, and that makes the skin less resistant to injury. So if you were to knock your damaged area of skin, you're more likely to get an ulcer, or at least a wound that heals very slowly. Treatment, well, I've put in very pale colours: injection, sclerotherapy, surgery, radiofrequency and glue, because we're not going to talk about those. But because I wanted to have something scientific, endovenous laser is what we'll mention, if that's okay. And there's a laser. So the basis of lasers was the theoretical work done by Einstein, who, you remember, here's the link. He was in the aneurysm talk as well, wasn't he? And there's a diode laser there. I hope I won't bore you with this. In the kind of laser that we use for venous treatment, the so-called gain medium is made of gallium arsenide, and these little dots represent in my diagram electrons resting inside that bit of gallium arsenide. So what you do is you put some energy into that, either electrical or light energy, and that excites the electrons and they buzz around at high energy, and then some of them fall back to their old energy state, releasing energy as photons, light if you like. And there are modifications of the laser technique whereby other electrons can be fired at these to make them more excited and so on, but just that's the basics. And then that emerges as laser light. Now, how's that different from switching on a torch? Or, well, this is a laser, of course, but how's it different from switching on a torch? Well, the difference is that torchlight is not coherent. In laser light, all the waves are in phase, so the troughs and the peaks are simultaneously going along together. It's also monochromatic, so all the waves are of the same wavelength. It's the same colour, if you like, and collimated, so they're all heading in the same direction. In a torch, they can be going off in all sorts of directions. And that's what makes the laser, if you like, so focused. Oops. Now, here's the electromagnetic spectrum. This is the bit of visible light. And the laser that we use, that I've been accustomed to using for lasering varicose veins, is 1080 nanometers, so around about this in the infrared spectrum. How does it work? Well, this is a picture of someone's leg. That's the top end of the leg, foot down here. And this is an ultrasound in a plastic sterile sheath. And the idea is that using the ultrasound, you find the vein and you put a needle into it, which gives you access into the vein, and that allows you to then thread the laser up. So here's the laser catheter, which is a long tube which goes up inside the vein, right up to this junction, as we call it, which is the point at which we switch on the laser. And as you withdraw the laser, it causes the vein to narrow down. And why does it do that? Because the laser energy heats up the blood to a very high temperature, which in turn heats up the endothelium, the lining of the vein, which doesn't like that, and it reacts by closing off. Next one. So here's an ultrasound of some blood vessels. If you imagine this is the top of your leg, your head is that side of the screen, your feet are pointing that way, and this would be your left leg. That's the vein in cross-section and the artery next to it. That's a vein. The colour just tells you there's flow in it. Here's another view of the veins at the top of your leg. This is the deep vein. Remember I told you there were superficial and deep veins, and the superficial veins dive down to join the deep veins. This is one of those junctions. There's the superficial vein with a couple of tributaries joining the deep vein there. And here's a view of a vein with this very sharp, bright shadow there, and that's caused by a needle which you're putting into the vein, which you're seeing on the ultrasound. So, the laser catheter goes up the vein to the junction, you fire it, switch it on, and as you withdraw it, the vein shuts down behind it. Next. There we go. Now this should be a video. See, oh, it works. Excellent. It should speak for itself. So there's the laser, finding its way up the vein. Up to this junction here, and the laser switched on, and as it's withdrawn, the vein closes off behind it.
Does it leave a discolouring or a blue?
It can leave a bit of a bruise along the line of the vein in the thigh, yes, but that's a temporary thing.
And so, how does the patient feel?
I did invite a patient to come along and tell you about it, but she's not here. But I'll tell you on her behalf. Well, I'll wait till this finishes, if that's all right. Well, that'll just go on till the end. So, what I didn't tell you was that before we switch the laser on, we inject a lot of fluid around the vein. So there would be a sort of sausage of fluid surrounding the vein, and that acts to absorb some of the heat so that it doesn't damage any structures neighbouring the vein, such as nerves, for example. It also has a bit of local anaesthetic in there because it's done with the patient awake. So some of the local anaesthetic will help numb it. When you switch the laser on, you sometimes get a pop, which is where a bubble of gas that's trapped in the vein will vaporise. And the patient may feel a kind of sharp twinge. But if you give enough fluid and local anaesthetic, that's usually enough. So no one has so far jumped off the couch saying, right, stop, I'm not having any more of this. But maybe once they're there, they feel they have to stay and finish the work. I don't know.
Does the fluid disperse on its own?
It does, yes. Yes, it gets absorbed by your body. The pros of laser treatment of veins, well, it's relatively quick. There's a quick return to activity. It's less painful than surgery in the main, and it's a so-called office procedure. In other words, you can walk in, have it done, and walk out an hour or so later. There's a trial called the CLASP trial, which compared foam injection and laser treatment and surgery, which is recently reported, and laser turns out quite well in that. And it is the first of the three which is recommended by NICE. The first in the list of the three that's recommended by NICE. The cons, well, there are these laser safety issues. You've got to wear laser glasses and have the room such that no one can walk in while your laser's on, even though it's inside the body and no one's going to get harmed by it being up there. There are no very long-term results to compare with. There are some equipment costs, and it's generally okay for large straight veins, not as good for small twiddly veins that you can't get the laser up. Beware persuasive advertising. These are just things you can find on the internet. So, to call something a leg-changing event is a bit over the top, would you say? But generally, you can get some decent results. So here are some varicose veins before and after. But of course, I would show you good results, wouldn't I? I'm not going to show you bad ones. Oh, that's the same one, isn't it? Never mind. And I think the best ones I got were these. Okay.
Can we talk a bit about DVT then, and in particular about it happening during or after an aircraft?
Yes. Well, DVT isn't very common. I can't give you a figure, but it isn't very common in people who fly. It's a little bit more common in people who fly who've got gross varicose veins. So that would be quite chunky varicose veins. Ways to prevent DVT, even in people who haven't got varicose veins, are simply to make sure you're well hydrated, so drink plenty of water as opposed to alcohol. Keep mobile when you're allowed to have your seatbelts undone and walk around. Take an aspirin. Ideally, you start the aspirin a good week before you start flying and continue it for a week after you land. And this is only relevant for long-haul flights. People who have had DVTs before are more likely to have another DVT. So perhaps you could argue that they should have greater precautions taken by, you can have injections which you give yourself to keep your blood thin. Or some people are on warfarin, which is a blood thinning tablet, to try and prevent DVTs.
What about stockings?
Yes, sorry, I didn't mention stockings. Stockings are helpful. They prevent swelling, which is not a pleasant thing, but they will also help venous return. And by keeping the venous return going, you'll help prevent stagnation in your veins. But moving about will do the job as well. So if you can't move, then stockings will do a good job for you. Okay. Is this the sort of time you would like to have a break? Or?
Yeah, I mean, is that the presentation done and we'll just move on to questions?
Or did you want more?
No.
Oh.
I mean, that's a perfect amount.
Okay, right.
Yeah, so if we want to take maybe a 15-minute break and top up your glass and